Our third speaker is Dr. Mohamed Ismail. It's a great pleasure for me to introduce Dr. Mohamed Ismail. He's adjunct professor of anesthesia at Western University of Canada, fellow of the Royal College of Physicians and Surgeons of Canada, and also cardiac and thoracic vascular anesthesia fellowship. A personal comment that I would like to do for Dr. Mohamed Ismail is that as long as I listen to your presentations and watching your work, I have noticed and always been amazed by your ability to make even the most complex concept understandable. I give the floor to Dr. Mohamed Ismail to analyze and present us neuromonitoring during cardiac anesthesia.
I'm here, yeah.
Yeah, you should be fine now. Thank you.
This information. As my dear colleague introduced me, I'm working at one of the centers that considered at Center of Excellence for Neuro Anesthesia Monitoring during cardiac anesthesia. There have been multiple publications and studies done at our center and shared with many people, and I would love to share some of our experience with you. Our topic today, I can't really stress enough on the importance of neuroanesthesia and neuromonitoring during cardiac anesthesia. So let's start with disclosure. I have no disclosures. If I mention some devices or name of devices, I was not supported, not paid to mention anything about any kind of neuromonitoring during this lecture. Today we will discuss some physiology about the brain perfusion, as well as the factors that affect brain perfusion, as well as we'll discuss the role or the importance of neuromonitoring during cardiac anesthesia. And as we all know that the main goal of our anesthesia is to give the patient the best outcome. To achieve that goal, we need the help of some tools and devices. As we all know that the anesthesia has major effects on the brain, including brain perfusion and brain function during anesthesia, as well as in the post-operative period. We usually say what happens in OR stays in OR, but I believe that what happens in OR accompanies the patient in the recovery, either it's normal recovery or cardiac surgery recovery unit, or CSRU as we call it here, as well as can even accompany the patient home if there is some complications like cognitive dysfunction can last for a long time, and some other complications as well. As we know, that neurological dysfunction can be really devastating, and it's the second in the incidence in cardiac anesthesia after cardiac complications. As we know from the anatomy and physiology that the brain has three components: tissue 80%, and CSF about 5 to 10%, the blood is 5 to 10%. There are many factors that affect the brain perfusion, and the most important one is the cerebral perfusion pressure. If the MAB is increased, the autoregulation can adjust the cerebral perfusion by decreasing the cerebral perfusion. And if the MAB rises, but there is no autoregulation, so the cerebral blood flow will actually increase. This is very important because, as we know, during cardiopulmonary bypass or CPB, the blood-brain barrier is disrupted. There are many studies done to emphasize the changes that happen during cardiopulmonary bypass to the blood-brain perfusion. And one of the important studies that they use functional and dynamic MRI with contrast preoperatively in day 1 after surgery on the post-operative period and day 5. They found that there is significant changes in the brain, especially in the frontal lobe, that happen in day 1 and in about 70% of patients, and that was resolved in day number 5. Those changes actually were correlated with neurological dysfunction that happened, especially cognitive function deterioration in the post-operative period. I'm not going to talk much about the physiology because I'm sure you are experts and I don't want to repeat those information that you know already. If the systemic blood pressure increases, as we know, as we just mentioned, it will improve the flow in the brain in normal situation. But what happens if the patient has stenosis, or the patient had previous stroke, or the patient has significant atherosclerotic disease that affects all the blood vessels in the body, including the cerebral blood vessels? Most of our patients that come for cardiac surgery, they have significant atherosclerosis. That's why they are here. So we are expecting those patients to have also significant atherosclerosis in different organs, including the brain itself. So with normal left brain arteries, the perfusion in the brain, especially the regional tissue perfusion, is independent on the blood pressure. It has autoregulation function. But if we have stenotic right brain arteries, that decreases the perfusion and the regional oxygen saturation and function as well. And this one is pressure dependent as well. So hypotension causes right hemisphere TIA, showed here in the graph, as well as in the MRI or functional MRI. So what are the effects of GA on the brain? I know most of us know the information, especially we have with us Professor Al-Ansari, which has a special interest in neuromonitoring in ICU. We all know that the intravenous anesthetics affects the brain and it's dose dependent, how much you give, especially with propofol and midaz and all these medications we use. The metabolism of these drugs also has big contribution. Usually the brain function is suppressed with those medications and the metabolic rate also decreases. The vascular or the cerebral blood flow also decreases and ICP increases a little bit. But the cerebral blood flow and the metabolism ratio is unchanged. What about inhalational anesthetics? Inhalational anesthetic actually reduces the metabolic rate as well as causes some cerebral vasodilation. It augments blood flow. But this, again, is dose dependent. So with 0.5 MAC, usually this suppresses the metabolism of the brain and decreases also the cerebral blood flow. If we increase the MAC to 1 MAC, this also continues suppressing the metabolism, but increases the vasodilation. This will be neutralized and there is no changes in the cerebral blood flow. If we increase the inhalation anesthetic beyond 1 MAC, again, the function will be reduced, and metabolism will be reduced, but the vasodilation effect will predominate and the cerebral blood flow will increase. Especially sevoflurane, which most of us use during cardiac anesthesia, will reduce the cerebral blood flow, will reduce the metabolism by about 38% at 1 MAC. The EEG will be suppressed at 1.5 to 2 MACs, and there will be disruption, reduction in the cerebral blood flow with cortex, and also has a small potential evoke of seizures. That's why we are careful with patients with seizure activity or history of seizure. But in general, anesthesia per se is protective to the brain. As we mentioned, it suppresses the metabolism and the function and improves the cerebral blood flow. So anesthesia actually is some sort of protective to the brain. It's not really harmful that much. How can we monitor the brain function in OR? There are many ways to look at it. We can monitor the function. We can monitor the blood flow, cerebral blood flow. We can monitor the pressure by measuring ICP. Also, we can measure the brain oxygenation and metabolism. We'll start with cerebral perfusion monitoring because this is the most important factor or element in our presentation today. Global cerebral perfusion monitoring can be done by using cerebral blood flow measurements, transcranial Doppler ultrasonography, as well as NIRS or near-infrared spectroscopy. Also, we can use jugular pulse oximetry that we use during neurosurgery, not in cardiac anesthesia per se. Regional cerebral perfusion monitoring can be done by brain tissue partial oxygen tension monitoring. Now, we will show some of the measurements that can be used for the brain in different surgeries. Here, carotid endarterectomy, and we can see here in the aortic coarctation and cardiopulmonary bypass, the EEG, TCD, cranial Doppler, transcranial Doppler, and jugular vein oximetry and cardiac. Transcranial Doppler or TCD, it's non-invasive as you know, just by putting ultrasound probe on the frontal area, and we use ultrasound waves to detect the flow. It helps us to detect intra-operative cerebral embolization during surgery on carotid artery and cardiopulmonary bypass as well. This is the device, and this is the ultrasound probe here under this, and it's used on both sides. This is the graph we get, or the image that we get from the ultrasound device, and gives us idea or information about the blood flow. We're measuring the blood flow velocity and measure blood vessels. In this case, it's the MCA or middle cerebral artery. Examination also is carried out through the temporal window or an orbital foramen magnum, but usually we use the temporal window. The probe we use 2 megahertz probe, and usually the MCA is the artery used to be measured for the blood velocity. Change in the velocity is proportional to change in the flow, considering the vessel diameter is constant. If the MCA has some stenosis, it will affect the readings significantly. When we monitor cerebral oxygenation and metabolism using brain tissue oxygenation, jugular pulp, as we mentioned, oximetry monitoring, as well as microdialysis catheter, and NIRS or near-infrared spectroscopy, which is the part or the topic we will use in the coming few slides. So NIRS or near-infrared spectroscopy is, we use the principle of absorption of NIRS or near-infrared light by chromophores in the body, like oxyhemoglobin and the oxyhemoglobin, cytochrome AA3. The light in the near-infrared region, the wavelength is 660 to 940 nanometer. And this narrow window is very minimally absorbed by the body tissue. That's why it can penetrate the tissues up to 8 centimeters deep, which is very, very significant, 8 centimeters in the brain. So we measure the regional cerebral blood flow, cerebral blood volume, cerebral oxygen saturation, and cerebral metabolism as well. So it gives us really lots of information. Biological spectroscopic window, and we see here the probes. We have 2 probes, one on either side of the forehead. There is light emitted from the probe, and 2 wavelengths are received on the other side. The wavelength we use, as we just mentioned, 660 to 940 nanometers. And because only a few chromophores like hemoglobin and oxyhemoglobin strongly absorb that light in this spectral range, this allows us to see the light that penetrates the tissue to the great distance, which we just mentioned, about 8 centimeters in the brain. And see the spectrum between here 660 and 940 is narrow, and hemoglobin and oxyhemoglobin usually falls in that category. Water and some other tissues has different wavelength in their absorption. Of course, there is some limitations, inability to assess the contribution of the extracranial tissue, signal changes, presence of intracranial blood, like blood clot or hematoma, also will affect the readings. It measures a small portion of frontal cortex contribution, so it doesn't measure the whole brain, just the part of the frontal part of the brain, which is frontal lobe mostly. Temperature changes also can affect nerves, especially we are dealing with cardiac patients and their temperature changes when they go on pump. Then when they come off pump, the temperature change can affect the reading. Also, the degree of contamination of the signal by chromophores in the skin. It's not validated as well. There is no significant or certain threshold that we can say this is the number that good brain perfusion should be at. For example, peripheral saturation is 100% or 93 to 100%. If it falls below 93, so there is problem. But here we can say the cerebral oximetry should be 60 or 70 or 80. It has wide range. Neurological complications that happen during and after cardiac surgery are, as I mentioned in the beginning, second to cardiac problems. And of course, it increases the morbidity and post-operative mortality and complications. The theory that thrombi and emboli that come from CPP or cardiopulmonary bypass causes cerebral infarction, and neurological signs also are evident in patients recover from anesthesia, and as well the disruption in the blood-brain barrier, as we mentioned. So theoretically, there are many factors or causes we can blame, including blood-brain barrier dysfunction, neuronal sympathetic level mechanism, and vascular mechanism, and the inflammation as well. So why those neurological changes happen in the post-operative period? We have on-pump patient and off-pump patient. In the off-pump patient, they share all the causes with the on-pump patients, including hypotension, anemia, low oxygen saturation, genetic factors, anesthetic agents we choose, previous neurological pathology. But with on-pump procedures, the embolization of gaseous and particular emboli, and of course, disruption of blood-brain barrier. How can we manage this? How can we deal with neurological dysfunction after cardiac surgery? Usually, those patients show signs of inability to follow simple commands within 6 hours of recovery from the anesthetic. They have some weakness on one side of the body, compared to other side, and some other neurological changes as well can indicate that the patient has some sort of stroke. Patients who are elderly or have hepatic or renal dysfunction, usually they need more time to metabolize and declare the anesthetic from their body. So we need to consider that before judging that the patient has significant neurological dysfunction in the post-operative period. Adverse outcomes can be categorized to type 1 and type 2 and can range from just simple cognitive dysfunction to cerebral death and non-fatal stroke, TIA, focal injury, stupor, and encephalopathy coma. Type 2 are deterioration in the cognitive function, deficits in memory, plus seizures. This graph shows the brain saturation. Usually, we have to have baseline to compare during the procedure. So the patient started with somewhere around 55 range in both right and left hemispheres. At some point, the right side saturation deteriorated. And as we can see, there is significant decrease in the brain saturation or oximetry at this point on the right side. After we noticed this on the machine, we just did a very simple maneuver, which removed the neck roll and repositioned the head. And we noticed that there is immediate improvement in the brain saturation, and the numbers again increased and are matching from almost 30 to around 70, 75. So this is very simple maneuver can be done if we see depth. Here, this graph again, but the first graph was for patient not like having other surgery other than cardiac surgery. In this graph for patients who had cardiac surgery with CBB, we see the patient started around 60, 65, and this is on room air, increased because we give 100% oxygen before induction. With induction, increased a little bit, then decreased with the effect of hypotension and medications. When we started the pump, the brain saturation or oximetry decreased. This is expected, but not significant because it's still above 50. Then when we give protamine and start weaning from CBB, the blood pressure drops and the cerebral blood flow drops significantly. That's why we can appreciate here significant decrease in the cerebral oxygenation and cerebral tissue oxygenation. When we give the second dose of protamine at the end, also we notice some dip or decrease of the brain oximetry. So what are the devices that can help us monitoring the patient during cardiac surgery? At this point, there are about 4 devices that approved from the FDA, up to my knowledge. The first one is ENVOS, cerebral oximeter, Foresight, Nunine, and Cereox. Different centers use different devices, but in our center, we use the ENVOS, the first one. And as far as I know, many centers in Canada and North America use the same device. So we'll focus on ENVOS to give some information about it and give also our experience with ENVOS. So it's in vivo optical spectroscopy. It's non-invasive, as we know. And it has a window in the body also because it uses the microvasculature to give us idea about the flow and saturation. It monitors the site, specific, adequate perfusion in the brain. Also, it's give us idea about the tissues beneath the sensor, as we mentioned, up to 8 centimeters. It provides real-time data regarding the balance or imbalance of the oxygen supply and demand in the brain. And this is the ENVOS. It's a 6th generation. I think this device has been updated and developed over the years. I remember about 10, 15 years ago, it was totally different than the one we use today. They integrated also some other information that you can get with the same device, including pulse non-invasive, non-invasive pulse oximetry and pulse variability, as well as hemoglobin and even carbon monoxide. All this information can be obtained from one device. So as we mentioned, there is no gold standard value for oxygen saturation in the brain or brain oximetry, but from the clinical experience we had, usually the normal values ranges between 58 and 82. In cardiac patients, the ranges are a little bit different, so it's from 65 plus or minus 9. Reduced value can be found also during cardiopulmonary bypass, as we mentioned, during initiation, as we just showed in the graph 2 slides the last couple of slides, because of hemodilution. Rewarming also, as we mentioned, that affects, and usually there is some sort of imbalance between the oxygen supply and demand because of rewarming. And sometimes also an inadequate bypass flow, when the surgeons ask for the flow to be reduced during surgery, this can affect the readings. Hypokarpia, BCO2 less than 40, also inadequate main arterial blood pressure, as well as anemia, can also decreases the reading. We'll continue with normal values, the difference between plus or minus 9 from the baseline on room air of the right or left, because the readings we obtain are from both sides, as we mentioned. So within change of 9 from the baseline, it is acceptable. But if the change is more than 10, at this point, we have to start thinking about the reasons or the causes that led to those changes. So what are the causes of possible asymmetry between the both sides? Carotid or intracranial artery stenosis that reduces the flow, infarction in the brain, as well as intracranial space occupying lesion, and excessive frontal sinus fluid. That's why it is very, very important to have a baseline reading. Because if we miss the baseline reading while the patient is awake on room air, we will not appreciate the changes that happen after. If the patient has, for example, any stenosis in the brain arteries, so the patient's baseline reading will be reduced. Then we will know that the reduction already was there from the beginning, not because any intervention that we have done to the patient. Critical values, if the change is more than 20% or the number we get is less than 50, that is very important and we need to do something about it. The critical threshold is taken as less than 45 or more than 25% change of the baseline. We see here both sides are monitored. Once the left side is 65, which is great, it's above 50, and the right side is 67 also, which is great. And the change on the right side is 0% from the baseline. The change in the left side is minus 3%, which is less than 10%, so it's acceptable, and we don't have to do anything about it. So it gives us both right and left side readings at the same time. So what to do if we see those dips or those decrease? We need to increase the inspired oxygen 100% to 100% until we figure out what is the reason or cause of this dip. Check the head position, as we mentioned. Removing only the neck roll and repositioning the head can solve the problem in some cases. Also the cannula positioning, we can ask the surgeon to check to improve the flow. Ensure adequate venous drainage as well by having good communication between the anesthetist and the surgeon, plus the cardiopulmonary bypass technician. If the PaCO2 less than 40, so we increase the PaCO2 to above 40. This improves the flow, the brain perfusion. Also, if the main arterial pressure than less than 50, we can increase it to more than 60 and see if that improves the problem. If hematocrit less than 20, so we need to transfuse blood. If none of the above helped the numbers to improve, so we need to do something different, which is increasing the depth of anesthesia that decreases the cerebral oxygen consumption, and that will protect the brain. Those changes that we can make are published and reported by our team, especially Dr. Merkin with John Merkin, which is a world expert in brain oximetry. This is the device. It's so popular enough that it was even in the media. There's a famous show, The Doctors, and they were talking about it and how anesthetists can use it to improve the outcome. In the old days, there were no enough studies to support the use of INVOS, especially at that time it was expensive to use it. But over time, it has been accumulated around 800 clinical trials and papers. 600 of them are peer-reviewed, are unique, and are done specially for INVOS technology. 3 prospective studies were done, prospective randomized controlled. So, and more than 800 centers on the world are using. 90% to 80% of the top adults and pediatric heart centers, including Western University in Canada. Approximately 6,000 units worldwide till the time of this presentation are already used, and more than 250,000 cases were done using the INVOS. So there were debate at the beginning. I remember I attended a meeting in the ASA in Washington 2012, and there was a presentation about neuro-oximetry, and there was some debate. Is it really cost effective? Can we spend more money to get the device and the probes? And if that really helped the outcome, or it's just a tool that we play with it in OR without really significant importance. So that paper actually was published in 2001, and 5 centers were enrolled in the clinical trial. It was more than 4,000 patients, and it showed that there is significant improvement in the clinical outcome using the neuro monitoring devices. One of the centers were University of Western Ontario. Also, it not improving only the outcome, it helped us to improve the neuroprotection, because the neurodysfunction usually is embolic, as we mentioned, because that disruption in the blood-brain barrier. That's why we need to detect that and do something about it in OR before sending the patient to ICU after already the insult was happened. Cerebral oxygen saturation is associated usually with early postoperative neuropsychological dysfunction, and also patients undergoing cardiac surgery are mostly susceptible to that. And as I mentioned in the beginning, when the functional MRI and dynamic MRI done with contrast in the postoperative day 1 showed around 70% of patients in the study had some neurological changes in the form of emboli in the brain, especially in the frontal lobes. And that was documented by Dr. Yao in 2004. See, 42% of the patients had neurological dysfunction if the area of saturation or desaturation stayed, or the period duration of cerebral desaturation more than 10 minutes. In other tests, it's about 32%, using 2 different tests for postoperative cognitive dysfunction. There was another important study, Goldman study. It was retrospective controlled and prospective intervention. So they compared around 1,200 cases which were done already before, which is the control group, to a prospective about 1,000 cardiac interventions. Actually, the patients were enrolled in the prospective study were more sick using the New York Heart Association classification compared to the patient were in the control group. So the results, if this device doesn't give much benefit, the results should have actually worse in the intervention group, not in the control group. So after the study was done, there is significant improvement in the cases that were done using the neuro monitoring device. compared to the other control patient that were done already without using the neuromonitoring technique. In the patients that were enrolled in the clinical trial that was prospective, 64.1% of them were actually more sick, class 3 and 4, using the New York Heart Association classification compared to the 30.7% in the control group. What about the diabetic patients? All of us know that diabetics are more susceptible to neurological complications in the post-operative period after they have cardiac surgery because of the significant atherosclerosis, the hemodynamic instability they show. Some of them have also ACE inhibitors and ARBs that causes vasodilation and causes vasoplasia that it's not easy to treat in the intraoperative period, that leads to hypotension and decreased cerebral blood flow, of course. Diabetic cardiac surgery patients were monitored with ENVOS in the study done by our team, Dr. Merkin and some others. And we were very vigilant to the readings during the study and trying to correct the depths or the decrease in the cerebral oximetry as quick as possible. And the results showed that there is significant improvements of brain function in the post-operative period compared to the diabetic patients which were unmonitored in the intraoperative period. So that actually made what we call leveling of the playing field for diabetics, because clinical outcomes were improved to the point that there were no significant differences between the diabetics and non-diabetics. So the outcome in diabetics were improved significantly to the degree that you cannot differentiate between the outcome of the diabetics and non-diabetics, which is very important. So this essentially leveling the play field for patients who traditionally have had poorer outcomes during cardiac surgery. What about cognitive decline in the post-operative period? Can we predict it? Can we tell which patient can have cognitive dysfunction or not? We know that almost 50% of the patients that have cardiac surgeries will develop some sort of cognitive decline. So a risk score formula was created by Slaughter and his team, and they found that any brain oximetry desaturation less than 50 for period more than 10 minutes will lead to a significant cognitive decline. And patient in the group that had the decrease in the brain oximetry have more than 6 days of hospital stay. So there is increased risk of prolonged hospitalization of patients that had decrease in brain oximetry less than 50% for more than 10 minutes. And 10 minutes, not continuous 10 minutes, it's cumulative period of 10 minutes during OR. So at the end, we need to emphasize that the brain by itself, our goal is not only to make sure the brain is well perfused and healthy. The bigger picture that we use the brain as an index organ to other deep body organs. So if the brain has optimized cerebral perfusion, we will similarly benefit and give beneficial effects on other systemic tissues, including other organs like kidney and liver and even the heart itself. So we're not focusing only on the brain, we are taking the brain, considering the brain as a window or an index organ for the whole body. And this is our conclusion. We cannot stress more on the importance of neuromonitoring during cardiac anesthesia, because there are events that could be silent and most likely has adverse effects on the patient in the postoperative period can be missed, and the devices that can help us to detect those events are very helpful for us to make sure the patient will have a good outcome. If you are a good sailor and you can get your ship safely through a cloudy and stormy day, I don't think if you are heading to a shore with rocks, you wouldn't mind a little help of small lighthouse that gives you an idea and information that can help you to navigate your ship safely to the shores and make sure the patient is having a good outcome. Thank you.
Thank you so much, Dr. Ismail, for your wonderful presentation. I thoroughly enjoyed it, and the example at the end. With your permission, I'll move on to the question and answers. So if anybody has any questions, we'd be happy to answer them. You can put them in the question and answer box. The question from Dr. Mohammed Suleiman asking, do you use EEG or BIS for your patients for these cases?
No, actually, for these cases, we don't use BIS or EEG because we believe that we care about the perfusion and the tissue oxygenation, and we believe that the envos or the information that we get from the envos are enough for us to navigate through the surgery. As you know, BIS monitor is not that accurate, as well as EEG during anesthesia with deep anesthesia and deep sedation is not that helpful. I think Dr. Ansari can also give us his comment. EEG is more useful in the post-operative period in monitoring brain function and detecting any seizure activity. But in OR, we did not have actually good results with it.
Professor Ansari, would like to give any comments on that?
Really, I want to say it is an highly beneficial and excellent lecture. Really, I enjoyed with your lecture, Dr. Mohammed. Very nice and informative lecture.
Thank you, Professor. It's a pleasure, honor having you.
Thank you.
I don't see any more questions in the chat box, so I think this will be it, or we can give a few minutes maybe.
I think that's it. You know, there's no more question. You can conclude now. Thank you very much for you. Thank you.
Thank you so much for all the speakers to be with us today and for all the attendees. And I think we'd like to conclude the session over here. I think it was a wonderful session. I enjoyed thoroughly all three presentations, and I hope to see more of those sessions and